So now we're going to start an IV on our patient. And since I couldn't find a willing participant today, I'm going to have to do my best with our makeshift arms here. And they're not hooked up to any fluid, so I'm not going to get the flashback, so I'm just going to have to talk you through it. And hopefully we'll get the practice in class. So I've done my AWOPs, I've checked my doctor's order. My patient's a little dehydrated. You can't tell that from her big lovely veins here. But we are going to start an IV on this patient. I'm going to have gloves. I'm going to have me a flush, and this is sodium chloride, 0.9 normal saline, and I want to be sure that it's the normal saline. They also package heparin in this in different strengths, so be sure you read it, because if it's blue or yellow, it's got something else in it, so you do not want that. So we want our saline. And I forgot something. Bear with me. Walk with me. Here we go. Okay. Sorry about that. We are going to start this as an intermittent device. Like you will hear in the book, it talks about intermittent devices. And that is essentially where we add a little pigtail to it. And in your kit, it's called a catheter extension set. And it looks like that. Now, without this, we can hook our IV fluids directly up to the hub of this IV side, but it does best if you put one of these on it. So we're going to put one of these on it. So in case the patient needs to shower or go get a CAT scan or something, we can unhook them from that and still leave them with this attached. And old nurses call them hep locks because we used to put heparin in them again, and now we don't put heparin, we just flush with saline. So I've got my pigtail extension. I have got my IV start kit. I have got me a flush. I've got gloves, and there's gloves in this kit, but I've got gloves. And again, they all come different. Like the IV that we're going to use is this one, but now some of the fancy ones come like this, and it's kind of already got the pigtail attached. Now this one is blue, so it's blue, what size? Blue 22. And this one is yellow, so what size is it?
24.
24. So the yellow is 24. But this one's blue, and this is what's in your kit, so we're going to use it. So I've washed my hands, I've identified my patient, and I've decided where I'm going to put it. Because you want to start low and work your way up, because you don't want to, essentially blow the veins up here, because if you try to go below it after that, then it will leak. So you always start low and work up. I always try to start on the non-dominant side, because that way it's a little more comfortable for the patient. So if my patient was left-handed, I would start on the right side, and I always start low and work my way up. Now, if my patient has had a stroke, or has had a mastectomy, or has got a dialysis shunt in this arm, of course I would not be able to use that arm, and I would need to go to the other side. But he's got a trach, and he don't look so good, but he's got a good right arm, so we're going to use it. Look how healthy that is. He's got big vessels in his arm. Again, you always start low and work your way up. And I am going to start his, just for the sake of you seeing better, I'm going to start it up high in one of these. Now, I've worked with nurses that can start them in the fingers and the digital veins, but I'm not that good. I am more of a inner forearm and a cubital area kind of gal myself, because there's something about, I think it's because the top of my hands are so thin, and my daughter would dare say gristly, that I am going to start low and work my way up. But you really have to see what the patient has. So I have washed my hands, and right now I'm gonna look and see what the patient has. Because with an IV, and in your kit, it comes with a tourniquet. And tourniquets are disposable. You do not take them from room to room. It's good for one patient, and then you throw it away. So when I'm doing my tourniquet, I'm going to start low, because I want to see what the patient has. Because you have to visualize the catheter you're going to leave in the patient is about that long. So you want to put it in a straight part of the vein. You don't want to put it in a part of a vein where the vein's fixing to split, because it won't thread past it. So you want it in a good straight part of the vein. because veins have got valves in them, and valves, that's the difference between a valve and a vein and an artery. A vein has got a valve that prevents backwash, and a catheter will not thread through that. So you want to be sure that you find a good straight piece of the vessel in order to thread it. So I'm just going to start low, and for your patient, if their hands are cold, I mean, you may, and when you tie your tourniquet, oh, let's do this. To tie your tourniquet, whether you're drawing blood or doing an IV, you want it to be tight enough to block off the venous blood flow, to back up blood into the vessels. You're not trying to amputate their arms, so you don't need to cut off their arterial supply, but you're going to pick it up, and you want your pigtails to be up. You don't want, I can't even do it, let me see if I can even do it wrong. You don't want to start this nasty habit, because if you do this, it's going to contaminate where you're going to clean. So that's a big no-no. You do it a little tight, and you do it where your pigtails are going up. That way it's not contaminating where you're going to be cleaning. So you're going to look, and you can have them hang their arm down off the side of the bed. You may even put some warm compresses on it. You can do light tapping. You know, you don't want to bruise them doing that mess, but you can do light tapping. Or you can take your alcohol pad. Oh, another one. Or, to me, I can see better if the skin is wet. So if I'm trying to look at an area and I've got their skin pulled tight, and if I can't see it that good, even with my light, and when I clean it, I really put, I really kind of scrub it. And I'm going to get that skin wet so I can see, and that will make my vessels pop out better. Okay, so once I see where I'm going to put it, I'm going to take my tourniquet off, because you don't want to leave a tourniquet on all the time. So I'm going to take my tourniquet off. But I think, well, I'm going to go right there. See how straight that looks? And if you can't see the vein, you can always palpate it. Like sometimes I go by my feeling in my palpating. It's this, not, you can lightly feel, because practice on yourself. Put your tourniquet on your loved ones and practice. A vessel is going to feel spongy. I know. My daughter's filming this, and she doesn't like my Skeletor hands, as she calls them, but they are, as you can see, the vessels in my hands. So now I'm going to get my supplies ready. So you got to back up a little bit. Number one, I'm going to pick my bed up at a better height for me. Okay. Now, just like the, I'm going to open all this up. Because in this kit, I've got a set of gloves, and these are sterile gloves, but you don't have to wear sterile gloves. You can wear clean gloves. It has got some plastic tape. You need to be sure if your patient's allergic to tape. It has got iodine in it, so you need to be sure your patient's not allergic to iodine if you're going to use it. It's got some alcohol pads. It's got a 2x2, and it's got a tegaderm in it with a little date area, so you want to always date your site. So I've got that. So I've brought my pigtail with me. I've got my saline flush. And just like our IV tubing, we want to prime this. So I'm going to open it. You don't want to stick your patient with a needle and not have all your stuff ready, or you're going to be in a mess. So I'm going to get this out of my thing. I'm going to put my clamp on it. Well, I'm going to flush it, so I'm not going to put my clamp on it first. Now I've just got this out of my package that was sterile, and I've not touched that, so I'm not going to clean it. Word to the wise, you see these little syringes? It's got an airlock in it, and if you're not careful, you will, they're hard to break the airlock, and you've got to break the airlock. And most nurses will kind of squeeze upward, and it will hit the ceiling with saline. How you prevent that is you pull back on the plunger just a smidge to break that lock. Then you can push the air out of it, because without shooting yourself or your friend in the face with saline. So I'm going to flush my tube, because again, you want it to be flushed. And I'm going to see how it's dripping. So I've got all the air out, and I'm going to put my clamp on it. Now, I like to loosen this a little bit, because it's an emergent and fun thing whenever you get your IV. You don't want to try to do 1,000 things. So I kind of loosen it and lay it on there for me. So when I grab it, when I get this IV started, I will have a better chance of being successful and not messing up. Okay, so I've got that primed and ready to go. I'm going to, let me open this up. So this is what you've got in your kits. And when you open it, it looks like this. Okay, so this is what it looks like, and I'm gonna show you. I'm just gonna take that off. You see that? That is the catheter. That's what's gonna be left in the patient. So it's plastic, it's flimsy, and then this is what you're taking out. Don't ever do that. So I've taken it out of my package, and here we go. So I've got it. Now I'm gonna put my gloves on. Now, despite what you may see other nurses do, you do not rip your fingers out of your gloves. You do not do it one-handed. You do it with both your gloves on. And I don't have one here with me, but sometimes I put a towel under my patient's arm to keep, in case they do bleed, then it doesn't get all over the place. So I'm going to put my tourniquet on, and you want to put it, I'll put it up here because we'll do an anicule. I'm going to put it about right there. You want to put your tourniquet on about, I'm going to have to put it lower because it ain't going to go on this weird arm. Wherever you're going to start, you want to put your tourniquet 4 to 6 inches above where you're going to stick. Now when you're drawing blood, you can do it about 1 inch up. But when you're doing an IV, this tourniquet needs to be 4 to 6 inches up above where you're going to stick the patient. So I've got my tourniquet on. My pigtails are up. I'm going to clean my site. And you're going to do a circular motion, in to out. Now your kit does come with betadine. So if I were going to use the iodine on this, you watch it, and you just crack it. And it will make a cracking sound, so don't panic. And that just gets the iodine down into the little Q-tip. And then I'm going to do it in a circular motion, make me a bullseye. You don't do back, forth. You got to do circular motion. Then I'm going to let it dry. Sometimes I use this, sometimes I don't. I'm not going to lie. Sometimes I do. Sometimes, especially on dark skin, that makes it harder for me to see the vessels, so I may not. So I'm going to let that air dry. I'm going to take my needle out. Now, these do not have safety devices on them, so be careful if you practice at home. Now, before I started, you always want to loosen the color portion. You always you don't take it all the way off, you just kind of loosen it like that. Then you look for your bevel, because the bevel has to be up. The little hole has to be up. Okay. Now, you seem awful close to that. Okay. I'm going to pull my skin taut and to the side. Again, I'm not going to do it like this, because what if I hit my thumb? So I'm going to pull my skin to the side. My bevel is up. I'm going to go in, because look how shallow those are. These veins are not deep, so I'm going to be pretty shallow. So I'm going to go in at about a 15-degree angle, and I'm going to go into the vessel, and usually you can feel it when it goes in. So on a real person, whenever you hit the vessel, blood is going to come back. You're going to have a little drop of blood come back in. It's called flash. You'll see a flash of blood. Whenever you see the flash, you've got to push it in a little bit further. Not much, about 1/8 of an inch. Now, so I'm in. I'm going to, at the same time as I am pushing the blue part in, I am pulling my needle out. And right before I get to where my needle is out, I'm going to take my finger, and up here above where that catheter is, I'm going to put pressure. Because if I don't, when I take my needle out, what's going to happen? Blood is going to go everywhere. So now normally on one that they use now, when you pull that needle out, the safety kicks in. So I've got this. I'm going to hook it up to the blue hub. I'm going to screw it in place. I'm not going to let go. I'm going to pop my tourniquet. I'm going to undo my clamp, and then I'm going to flush this with saline. And as I am flushing it, I'm paying attention. I want to be sure that it's flushing normal, that it's not blowing up, because if it puffs up real big, then you've blown the vein or it's infiltrated. So if you're not sure, you can pull back on your syringe, and if you get blood, you're in. So I'm going to flush, 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 flush. Let's hope this don't squirt out on my bed. So I have flushed it, and I'm going to clamp it. Now before I stuck, now did you notice I cleaned it and I didn't touch back over it? Once you clean it, you can't do this again. So I did not do that. So I cleaned it, then I stuck it. Now we're going to use your Tegaderm. You peel the back off, and you're going to cover the blue part to hold it in place. That's why you don't touch it, because if you've touched all over that, then your germs are stuck up under that. So you don't do that. So I'm going to take this off. And I don't cover my hub with this, because what if I needed to change my tubing? Then if I had to take all this off, I would stand the chance of pulling that out. So I try not to cover that connecting point. And I'm going to take this off. Then you can date it. And I will tell you, because now that I've done it this way, if I'm going to use the betadine part, I always use the betadine first usually, and then I do the alcohol over it, because there's just something about leaving that betadine on the skin that I don't particularly care for, but some people do it this way too. So I'm going to date and time it, and I want to do it up here. I don't want to cover up my insertion site, because every time you come in, you're going to look at that, and you're going to be sure that it's going in good, that it's not red, that it's not infected, and you're going to do that. Then I'm going to unhook it. I've got it clamped. You want to keep it clamped because you don't want blood to backwash into this, because it can cause it to clot off. Now I'm going to take my gloves off and do hand hygiene, and I'm going to put some more tape on this, because I don't want it to come out. And taping it is up to you. I'm old school. I usually do it like this and put a chevron. Let me take that off. That's going to worry me. And then I may put another piece of tape across here. And then that's why you don't want to be sure that your patient's not allergic to tape. And then I will tape it up here. Or however you can figure out however what it wants to lay to make it right, so that it's not got a kink in it. And that's just how that would want to lay, and it's not wanting to stick to my mannequin. But I hope you get the idea. Now, okay, so it's clamped off. So now our patient is ready. So this hub right here, our IV that we started a while ago, this is ready to go. I would just have to scrub my hub for 15 seconds. I'm going to unscrew it. Then this screws, I would have gloves on, directly into there. Then I would open this clamp, check all my clamps here, program my pump, and then the patient could go. Now if I want to hook tubing up like that, then I won't take my tubing again, because that makes it heavy. That makes it heavy. So I would put another piece of tape or loop it up. You know, you have to get creative sometimes, because you don't want the patient to pull it out. And we'll tape it good. Because you don't want to take the chance of that pulling out. So it's not in a bendable area. Like if you put that patient's IV in their wrist, in their hand, you want to be sure it's not in a kink. The same thing in the inacubital space. If you put one there, the patient has to keep that arm straight, or every time they bend it, it will kink and set your alarm off. So There is our IV. Now, to take it out, before you take out a catheter, before you take anything out, whether it be a catheter, an NG tube, or this IV, you need to check your doctor's order. Because again, doctors may tell you at the bedside, take that IV out, then he may get back to the nurse's station and change his mind. So always check that doctor's order, because you need one to take it out, and you'd hate to take one out and then have to restart it back because he changed his mind. So you're going to check your doctor's order. You're going to wash your hands, gather your equipment, do your AWOPs, and tell your patient what you're going to do. And I'm going to do something with this before that, but when you take it out, you're going to be sure when you take the catheter out that you have to document that that catheter is intact. If you take out this blue hub and half of that catheter is gone, then that's an emergency thing. You have to let your charge nurse know, let the doctor know, because that means that half of that plastic catheter is floating somewhere in their body. So you always have to document that the 22 gauge IV in their right forearm was discontinued, catheter intact. Now, have I ever had that happen? Knock on wood, no. But you always want to look and be sure that it's all there. Because if it's in their antecubital space and they're bending their arm and they're bending their arm, I mean, that could easily break off into their circulatory system and cause a clot, stroke, death. But, okay, so here's our patient, and our patient came in, and the doctor has ordered him IV fluids at 125 an hour. He's getting Rocephin twice a day, and then 2 days from now, or even the next morning, the doctor may come in and say, okay, I want that patient up walking. He's drinking now, so let's discontinue the primary line and just do the Rocephin twice a day. So you don't want the patient to be tied down to this all day long. You want to get them up and move and walk, so you can break it down to the intermittent device. And that's just where, again, I always have gloves on when I'm working with IVs. This is where the little pigtail comes in handy. That you will just break it down to here, clamp that off, unhook it from here. I've got a cut on my finger, that's really good.
Clamp your line too, wouldn't you?
Oh, yeah, I don't have, well, I turned off my pump.
Okay.
Boy, I got that on there good. Let's just see here how I can get a hold of it. The world is full of good intentions. Okay, we're going to stop it here, and then we're going to do another one.